Welcome to Modern Medicine. I'm pleased to have with us today a special guest, my colleague of the last 25 years, Dr. Neil Fisher, who's a general surgeon in practice in Schuylkill County. Neil, welcome, and thanks for taking time out of a busy schedule to join us.
Thank you very much, Dave, for having me.
Yeah, terrific. I wanted to look at your educational background to start. What kind of training did you take before you were able to, say, hang out the shingle as a general surgeon?
A pretty traditional approach. I graduated from Albury College and then matriculated to Philadelphia College of Osteopathic Medicine, graduated there in 1983, and then did a 5-year internship residency program at the University of Medicine and Dentistry of New Jersey, located in Stratford and Camden.
Yes.
So it's a 5-year program. Because of the osteopathic medicine requirement, the first year is considered an internship, right, and then the last 4 years is a residency. And I finished that in 1988.
Now, Neil, you mentioned Camden, New Jersey, and that always had a reputation. I grew up in the suburbs of Philadelphia, but Camden was always a rough and tumble place. That must have been a fantastic place to do general surgical training.
Absolutely. And we were a level 1 trauma center. So our level 1 trauma center was actually it was Cooper Hospital, located in Camden, New Jersey. So yes, it was. We had an awful lot of penetrating trauma, gunshots, stab wounds, as well as motor vehicle accidents. So yeah, it was quite an experience.
Yeah, that is one place I would not like to be the coroner of, is that county.
I can understand
New Jersey.
that.
But you mentioned level 1. What exactly are the levels? Just a little aside, but I think the viewers would be interested in what a level 1 trauma center is. And I know we were trying to get designation up here, but it wasn't at that high level.
Correct. A level 1 trauma center is usually very large hospitals, and they have requirements to be a level 1 trauma center. Is you have to have board certified trauma surgeons in-house 24 hours a day. You have to have the ability to have neurosurgery, high-level orthopedic surgery, anesthesia, and critical care medicine available 24/7 in-house, not by phone that they arrive. They're in-house. So like when a multiple trauma is announced actually before it hits the door, there is a response team waiting for the trauma as it arrives. I also believe they have to have helicopter capabilities on site. So that's level 1. Level 2 is between level 1 and level 3. What we were trying to get here in Schuylkill County was level 3. And level 3 is you don't have to have surgeons in-house. They have to be able to respond within a 30-minute time period. We obviously don't have neurosurgery, and you don't have cardiovascular surgery in-house. That would have to be airlifted out. And then level 2 is between those two designations.
Yeah.
It's interesting that statistics have shown, Dave, that the survivability and mortality rates from penetrating trauma and motor vehicle accidents are directly correlated to the closeness to a level 1 trauma center.
Yeah. Where are the level 1 ones in our region?
In our region, we have level 1s at the Geisinger Medical Center in Danville, the Hershey Medical Center in Hershey, and the Lehigh Valley Trauma Center in the Lehigh Valley, as well as I think St. Luke's also might be a level 1.
Yeah.
Point of fact, as I mentioned to you, is that you're familiar with the mass shooting at the nightclub in Orlando, Florida.
Yes, tragic.
That the response, first of all, the results from that. I forget the exact statistics, but I believe they had somewhere in the range of like 30 to 40 major injuries that all descended on the Orlando level 1 trauma center, and they had no fatalities of any of those people. That
if you made it to the center,
to the trauma center, you made it.
Fantastic.
Which speaks volumes for the medical personnel in that facility.
Absolutely. Okay, well, you trained in Philadelphia and South Jersey. what the heck brought you up to the cold region, which is certainly our boon, but
That's
what got you up
interesting.
here?
Well, I went to medical school on a military scholarship, an HPSP scholarship. So as part of that scholarship offer, you're required to give back time to the military. So when I finished, I was on an Air Force scholarship. When I finished my training in 1988, I entered active duty in the United States Air Force and served 3 years as a general surgeon in the Air Force. That ended in '91. My wife and I had started a family during that time period, and we're looking to relocate back to the East Coast. I was stationed out in Wyoming during those 3 years. So we're both looking to get back to the East Coast. I grew up in the Wyoming Valley, which is about an hour north of here, and my wife grew up in Drexel Hill, outside of Philadelphia. So we were sort of looking for something in the Middle Atlantic states, and through multiple job searches and interviews, ended up here.
Wonderful. I'm going to do another aside. What are your hobbies? How do you unwind when you're done operating on people?
Well, I guess the single one, which is probably what everyone says, I love to spend time with my family.
Yeah.
Love my kids, love to spend time with them and my wife. But if I do have time to do something in the summertime, I like to golf.
Yeah.
I like to hike. Don't get to fish very often anymore, but I used to love to do that. And in the wintertime, I like skiing.
Yeah. I'm recalling that this was a distant memory, but St. John the Baptist Church would have Stations of the Cross at Easter time.
Yes.
And didn't you play somebody in the
Yeah.
in the living?
Yeah.
So you have acting.
Yeah. Yeah, I was Pontius Pilate.
Were you? Yeah.
Yeah, the 1 year, and the year before that, I was a Roman guard.
Yeah.
So that was my brief thespian experience. They didn't ask me back.
All right. Well, now for the remainder of the session, I'd like to focus in on some of the major advances in the field of general surgery. And what would you say some of those are?
I would say the biggest one over the last 25 years has been the invention and development of laparoscopic surgery, or minimally invasive surgery. It has pretty much revolutionized the surgical approach for a vast majority of operations that are done laparoscopically. And why that's such an advantage is that it's really cut down on post-operative pain, cut down on post-operative recovery, cut down on hospital stays, and gotten people back to normal lifestyle quicker than conventional surgery. It's just progressed over the last 25 years from in the general surgical. I mean, gynecologists were doing laparoscopic surgery back in the 70s and 80s, but that was via a single port type thing where the surgeon would literally look through a telescopic camera into the body. When I talk about laparoscopic surgery, what I'm talking about is the technological advances where the camera became a three-dimensional thing, and what we watched, we weren't looking through the camera anymore. We were actually looking at a TV screen and seeing what the camera was seeing on a TV screen. So it created a two-dimensional look of the operative field. And when I talk about the advancement of laparoscopic surgery, that's basically what I'm talking about. And that's started out with gallbladder surgery, and then has progressed to pretty much virtually every organ system in the body where you have minimally invasive surgery.
I know when I was a medical student, gallbladder surgery was about a foot-long incision below the ribs on the right side, and the people would be recovering for six weeks, couldn't
Correct.
lift things, and
Right.
they were wiped out.
Right.
And now it's most of the time you can't even find the scars.
Exactly.
And they're out in a day, 2 days hospitalization.
Same day.
Same day.
It's outpatient surgery now,
yeah, unbelievable.
for the most part. People go back to work if they're not doing strenuous activity the day after surgery, 2 days after surgery, and then resume normal strenuous activity within 2 weeks.
Okay. Well, I'm going to use that, the laparoscopic revolution, as a segue into robotic surgery. What's your impression there?
Which is a very natural progression. Because essentially robotic surgery is laparoscopic surgery. The only difference, it's small site incisions, so it's actually just a natural advance of minimally invasive surgery. The difference being is you have the cameras and the instruments are now coupled to a robot, and the operator or the surgeon is actually away from the table, away from the body, and looking through a monitor to direct those the camera and those instruments. And what that does is it's much more precise. It allows for much finer dissection. There's no handshaking or tremors, and it's pretty exciting stuff.
I've heard that this may extend a surgeon's useful operating lifetime.
Exactly.
What is your impression of that? Because I think when those gynecologists were looking through the scope at very weird angles, they probably developed a crick in the neck, etc.
Exactly.
But here it's much more relaxed.
Yeah, you're in a much more ergonomically favorable position sitting at the monitor as opposed to standing. Because some of these surgeries can take several hours.
Sure.
So it saves backs and necks and knees and the natural.
And when you're getting to be our age, you appreciate these little.
Exactly.
Yeah.
But the natural, in the natural course thing, as people get older, like tremors are almost inevitable, and the robotic surgery pretty much eliminates that for a vast majority of things.
Well, Neil, we're going to take a commercial break right now, but when we come back, we're going to focus on some more advances, major advances in the field of general surgery. Thank you. Welcome back to Modern Medicine. And it's a great pleasure to reintroduce Dr. Neil Fisher, who is my colleague of the last 25 years, working together in the anthracite region. And we've seen a lot of developments in everybody's field, radiation for me, but general surgery for you. We've talked about a couple of the advances, but during the break you mentioned to me something called natural orifice surgery. What the heck is that, and when can I get one?
I'm not sure you're going to be able to get one anytime soon, because although it seemed real promising 2 or 3 years ago, it has not really held its merit in scientific scrutiny. But basically what it is, it's called NOTES, which is natural orifice totally endoscopic surgery, or NOTES. And for example, we were talking about gallbladder surgery. They would go down through a person's mouth with a camera and then penetrate the stomach wall with the camera to identify the gallbladder, and then actually remove the gallbladder and then bring it back up through the stomach. Other orifices that have been used has been the vaginal introitus.
Which would be an area that could be rendered sterile with enough betadine or whatever.
Exactly. So taking out appendixes through the vagina or taking out ovaries through. So it's been something that has been, the industry really was promoting it. The makers of these various instruments.
Scopes and everything.
But it just hasn't. It just hasn't passed the medal of scientific scrutiny to this point.
Well, I could see one theoretical advantage, because anytime you make a cut through the muscular wall of the abdomen, you've created a weakness which could potentially turn into a hernia. Now, again, the small incisions for the laparoscopic are pretty small, but I think theoretically is possible. Could you talk to us about your experience with hernia repairs, and what are the new developments in that aspect of general surgery?
That has been a very exciting field, Dave. Hernia surgery, as you know, hernias have been around as long as man has been around. And there's been just constant evolution of techniques and what have you. But what really revolutionized hernia repair was the invention of synthetic meshes about 25, 30 years ago. And those meshes have just continually evolved into better and better products. And now we have also in our armamentarium biological meshes, which are...
What's a biological mesh? I know about Gore-Tex, that you can make a weatherproof coat out of it.
Exactly.
How about the biologics?
You mentioned Gore-Tex, PTFE, or some of the other, Marlex, or some of the other synthetic meshes. The biologic meshes are made from usually like pigskin or something of that. They're from a natural origin, like pigskin. Their advantage has been in a contaminated field. When you had a large hernia defect and it was a contaminated field, like say a perforated bowel or something of that nature, you really couldn't use a synthetic mesh in that situation due to the very high risk of infection of the mesh. Biological meshes, on the other hand, can be utilized in that situation without a concern for infection. So that's where they had their niche. Now, of late, there's been some studies that have shown that with synthetic meshes, they can actually be used in a contaminated field, but that's kind of early in that.
My concept of the biologics is it provides a temporary scaffolding or framework, and then your own tissue kind of infiltrates and takes it over.
Yes, I've been in conferences where I've seen studies where like a biological mesh was used on a repair, and then that repair 3 or 4 years later was actually looked at under a microscope, and you couldn't tell the difference between the biological mesh and the natural fascia. Yeah.
Well, I'm going to do another sidebar here. One of my pet peeves on TV, on billboards, we see our colleagues in the legal profession, and they're always advertising for some damage that has happened to a patient. And I'm hearing stuff about meshes. Do you have a perspective on that?
Yeah, there was a mesh product a couple years ago that had a retaining bar around the outside of the mesh to kind of give it stability inside the body. And there was some erosion of those rings that caused some like bowel injury. And I don't know the exact data, but it's something on the order of, out of like 10 million meshes utilized, there was like 7 or 8 that caused this problem.
Right? Oh my gosh.
Yeah, they're very safe.
Very safe.
But you mentioned that the next big leap in hernia repair surgery has been the rectus total abdominal release procedure that's used in combination with mesh, because you mentioned how the meshes or the biologics cover this big defect, which is good, because prior to meshes, we had nothing to cover the big defect. So now we had the meshes, but even with the meshes, those big defects left open are prone to high rate of recurrences. So even with meshes, in large ventral hernias or incisional hernias, recurrence rates are in the 30 to 40% range. This retrorectus transabdominal release procedure actually alters the anatomy of the human body, in that it actually, you go in and you through surgery, release the rectus muscle, which are the 2 muscles that go up and down in your body. You actually release their attachments laterally so that you can bring them to the midline and actually close the midline with your own natural tissues. And then the mesh is used as a reinforcement to that closure. And that, to date, has shown the best results as far as large incisional and ventral hernia repairs.
I'm going to use that as another segue. We had talked about it on the break. A very common phenomenon I see in older men, especially when they're getting on and off the exam table. There is a bulge centrally when they would try to rise up. The medical term, diastasis recti. It's kind of a medical curiosity, but you were telling me that oftentimes you'll be asked upon by a colleague to consider repair of that. What are the pitfalls there?
The pitfalls are that if we, without turning back the time clock on a person's back 20, 30 years or a loss of significant weight, those repairs, because there's not really a break in the fascia, so If it's not broke, don't fix it. So like, there's
Yeah.
no actual break in the fascia, so you cannot make the fascia more tight than it already is. There is no break.
Yeah.
So the only thing that you have is a lateralization of the rectus muscles, and you can't fix that surgically.
Will exercise help?
No, not really. If you had someone lose a significant amount of weight, it would help.
Yeah. Okay. Speaking of weight, there's a whole field in general surgery, bariatric surgery. It reminds me of what my good friend John Flanagan once said. I resemble that remark. But bring us up to date on that, because I've had patients that have gone for it. Some, a wonderful result. Others, problems. And
well, complications in surgery are, when you have people that have high BMIs, they're very much prone to complication. However, bariatric surgery done at a center of excellence where there have fellowship-trained bariatric surgeons have minimized those complications. And it becomes a whole team approach. It's not just the actual surgery. You have to have like psychological and dietary components involved. But the actual surgery itself has gone through a remarkable progression over the last 20 years. Started out with like major anatomical changes, small bowel reversals and Roux-en-Y's, and to now, the mainstay procedure now is the gastric sleeve, where they just basically minimize the size of your stomach. They exclude 3/4 of your stomach, so your stomach's just not there anymore, and so you cannot, you just can't take in as much calories or food. And I think the literature has pretty clearly shown that a successful bariatric surgery has reduced hypertension, reduced diabetes, reduced hernia formation, extended longevity of people's lives. I mean, it's remarkable, successful bariatric surgery, what it can do for a person.
Well, when we do talk about the complication rate, what the fellow travelers with the obesity, diabetes, and hypertension, and they can contribute to complications, certainly.
Exactly.
Well, to wrap up, Neil, I'd like to talk about wound care. I know you, as part of your practice, you're involved in wound care and hyperbaric medicine. Yeah. So, what's been your experience, and where are we headed in that exciting field?
It's another very exciting field, Dave. There's multiple advances in wound care, from the traditional, surgical debridement and just good, attention to local detail in wound care, to the proliferation of skin substitutes. Started with Apligraf back in the 90s and has progressed now to where there's just, every 6 months there's a new product on the market from a different company. And the reason there's such a proliferation is that they work. They do tremendous benefit to get the, obviously the wound has to be cleaned and has to be taken care of, but once the wound is clean and you put on these skin substitutes, they deposit growth factors, which are, inherent to the substitute, into the wound itself, and basically jumpstart the wound towards the natural healing cascade. Some of the origins of these, like I mentioned Apligraf, that comes from human neonatal skin. The newest product on the market comes from human the lining of the placenta, amnion and chorion. And then there's a lot of porcine or pig origins to these materials.
Yeah. Neil, I think we're just scratching the surface here. I'm going to have you come back so we can explore in depth some of these exciting topics
in
general surgery. But again, thank you for taking the time from a busy schedule.
Thank you.
Much appreciated, buddy.
Thanks.